Welcome to today's webinar, Caregivers, an essential part of the myeloma care team. And it is now my pleasure and at this time to turn the program over to Mary Jerome at the Multiple Myeloma Research Foundation, who will begin the webinar.
Thanks, Kelly, and hello, everyone. My name is Mary Jerome. I'm the Director of Medical Communications and Education at the MMRF. Thank you so much for joining us today for this webinar. I'd also like to thank AbbVie, Amgen, Bristol Myers Squibb, Celgene, Genentech, Janssen, Carrier Pharm, Novartis, and Takeda Oncology for providing the educational grants necessary to support this webinar. First, I'll talk a little bit about the MMRF. The MMRF is a patient-founded organization started in 1998 by Kathy Busey soon after she was diagnosed with multiple myeloma. We have a keen sense of urgency and a laser focus on extending patient lives. As many of you know, multiple myeloma is a highly heterogeneous disease, which means every patient's disease is different. So each patient should receive a treatment that's specific to his or her type of myeloma. That is the promise of precision medicine. With such a high degree of diversity, the MMRF is focused on generating and aggregating as much data as possible to capture the full picture of myeloma. The cornerstone of this effort is our COMPASS study, which now has the largest genomics data set of any cancer. We make sure that the data that we collect is available to researchers worldwide to develop hypotheses for new, more precise treatments, and then we push those hypotheses into clinical trials. This is our end-to-end precision medicine model. We are already expanding our genomic data collection efforts beyond COMPASS into the relapsed, refractory, and MGUS and smoldering area as well. And recently, we announced several major multi-million-dollar investments in research that leverage this model, an effort in immunotherapy, an effort in multiple myeloma prevention, and also in high-risk multiple myeloma. You can read more about our model and these efforts on our website. To follow all of our latest research and educational updates, I strongly encourage you not only to visit our website, but also to follow us on Facebook and Twitter if you are active on those channels. I'd also like to mention that we now have a new Multiple Myeloma Research Foundation Facebook community that is up and running. You can access our new Facebook groups right from our homepage. It's on the left under the Groups tab on the left-hand margin. We'd love to have you join us and join other patients and talk to each other about your questions and issues. And we will also have these groups monitored by nurses who will be able to help answer your questions. So we encourage everyone to join these new Facebook groups. For today's webinar, I'd now like to introduce our speakers. Kathleen Colson is a clinical research nurse with the Multiple Myeloma Program in the Jerome Lipper Multiple Myeloma Center at the Dana-Farber Cancer Institute in Boston, Massachusetts. She has presented on the topics of multiple myeloma treatments, supportive care, and side effect management at many symposia and workshops, both nationally and internationally, and she has authored numerous publications on these subjects. Alan and Deb Osborne are a husband and wife patient and caregiver team who have devoted much of their time to volunteering for both the MMRF and the Dana-Farber Cancer Institute. At DFCI, they serve on the Patient and Family Advisory Council and assist with numerous patient education and support activities. Each year, they participate in the MMRF Team for Cure's 5K walk run in Boston, and they have written blogs for the Community Gateway, and will continue to write these blogs for our new Facebook groups. Alan has spoken at MMRF patient summits and frequently addresses support groups. And Deb facilitates a caregiver's coffee hour at the Dana-Farber. Today, Kathy, Alan, and Deb will provide information on the following topics: making sense of the multiple myeloma diagnosis, the treatment plan, what to do when myeloma comes back, any treatments that are on the horizon, and the role of the caregiver. Now it's my pleasure to turn the webinar over to Kathy Colson. Kathy.
Hi. Hi, everybody. Thank you very much. Good afternoon, everyone. And I want to thank the MMRF for giving me the opportunity to discuss the ever-changing world of multiple myeloma. Okay, here we go. So what is multiple myeloma? Multiple myeloma is a hematological blood cancer that develops within the plasma cells. It's the soft, spongy tissue at the center of our bones, and our plasma cells make our antibodies. Those are our immunoglobulins to help fight bacteria and infection. And what happens here is that there's some genetic damage with the plasma cells, and they become malignant, and they're called monoclonal antibodies. And over here in the picture, you see the picture of the immunoglobulin. We have what we call the heavy chains, or we see the serum, which we see the IgG or IgA, or the light chains, which are the kappa and lambda proteins. And this is what we monitor when we're looking for the patients are responding or progressing on therapy. So how common is multiple myeloma? Multiple myeloma is the second most common cancer of the blood, second to non-Hodgkin's lymphoma. There are about 30 cases a year that are diagnosed with multiple myeloma. And it's interesting that we have 103,000 patients that are living in remission with multiple myeloma. And the number of patients living with myeloma has increased over the last few years, and not because of their being diagnosed, but rather the patients are living longer due to new therapies that have been developed. The average age of the median age of diagnosis of myeloma is 69 years of age. So myeloma, affects, many of the organs in our body. The most common symptoms of multiple myeloma are fatigue and bone pain. Patients can have low blood counts, and this is due to the overproliferation of the abnormal plasma cells within our bone marrow, which causes our platelets, our white count, and our red cells to decrease. And this can lead to weakness, fatigue, and infection. Myeloma patients can have a decreased kidney function, and this can be seen in about 40% of patients of multiple myeloma. And the decreased kidney function is related to the small, light chains, those kappa and lambda light chain proteins that are filtered through the kidneys, causing tubular damage. Myeloma patients, up to 70 or 80% of patients can have some type of bone damage, which is found upon a diagnosis. The bone damage, the common sites are the spine, the pelvis, and the ribs, and this can lead to fractures. And then we have, bone turnover, and this is the bone turnover. This is results that causes patients to have hypercalcemia, because what happens when you have bone breakdown, this releases large amounts of calcium into our bloodstream, and the patients have high calcium. This can be a medical emergency that can cause patients to have some types of confusion and weakness. So it's very serious, and that is a medical emergency. It's interesting, about 10% to 20% of patients with newly diagnosed myeloma do not have symptoms, and generally patients get diagnosed in the latest stages of their disease. But making sense of the diagnosis of myeloma, as we know, is a life-changing event for both patients and their families. But fortunately, great strides have been made in the diagnosis and prognostic processes, which help with great treatment approaches that we have today. So very important is to know about our labs and learn about the labs that we have. So the blood and urine tests, as well as the bone marrow biopsy, are part of the initial evaluations to help confirm the diagnosis of myeloma and then help to guide us with a treatment plan. So with the blood tests, we have the CBC that looks at your red cells, your platelets, and your white cells. We have the chemistries panel that looks at your kidneys, it looks at your electrolytes, it looks at your calcium and your liver function. Beta-2 microglobulin, that also is a marker for myeloma. The SPEP test that we do all the time on our patients monthly, this looks at the quantity of the abnormal protein. So this helps guide us to see if a patient is responding or progressing on therapy. Immunofixation lets us know if the cells, the myeloma cells or those plasma cells are normal or abnormal. And then we have the serum-free light chain, and those are those light chain proteins, the kappa or lambda. The urine test that we do, we have patients do the 24-hour urine analysis, which is very difficult for patients, and we understand that. But that lets us see how much abnormal protein is produced in the light chains in the urine over a 24-hour period. And then we have the imaging. We have the x-rays, the MRIs, the CAT scans, and the PET scan. And these images are very, very important because they help to assess changes in the bone structure and determine the number and size of tumors that we can be seen in the bone. So the diagnosis of myeloma, we do the bone marrow biopsy test. This is performed to assess the percentage of myeloma cells in the bone marrow and to determine how much they differ from the normal cells. And so also when we do the bone marrow, we get the tissue, we get the aspirate, and in the aspirate, we're looking at a cytogenetic analysis, we look at karyotyping in fish, and these tests are very useful for helping us to define if a patient has high risk or low risk myeloma and what therapies we need to target for those patients. So putting all of these test results together, this is what the physician does. He looks at the imaging results, the blood and the urine, the genomics, the bone marrow analysis, and the staging. And putting this together comes up with a plan of treatment for the patient. But, you know, we need to remember that every myeloma patient's disease is unique. Many different factors play an important role in the treatment decision by your physician. So after the establishing a myeloma diagnosis, these are some questions here you can find out from your doctor. So it's important to say, you know, what type of myeloma do I have? Because I often ask my patients, what type of myeloma do they have? And they'll say multiple. And there are isotypes like the IgG, the IgA, lambda, or kappa. So it's important to know this. Important to know the stage, what your cytogenetics are. Ask if they can, bank your bone marrow tissue for future analysis, and what treatment considerations, should you talk to your doctor about. So this is always be aware that your doctor does want you to hear from you and does value your opinion as far as your treatment decision. So looking at treatment overview, obviously the goal of treatment is to induce remission. We want to get a nice response. We want to improve performance status. Certainly minimal side effects, and obviously prolong overall survival, and most importantly, preserve function in quality of life. So your personal treatment plan, partnering with your healthcare team, when we look at this, your physician's looking at the age and your general health and other conditions. They want to make sure that you don't have comorbidities, you don't have heart disease or kidney disease, or lung disease. They want to look at your test results and the symptoms that you may have. Your preferences might be, obviously, we want to eliminate and control disease, your willingness to tolerate some side effects that we may see, symptom relief in personal lifestyle and situations. And so this is where, you can talk to your doctor about, well, maybe I need an all-oral regimen because, I'm working full-time, or I'm traveling and I don't have time to go into the doctor's office to get something IV. So the doctor does want to hear from you. He wants to know what your preferences are, and this is all part of shared decision-making between you and your physician. So don't be nervous when you're in there talking to him. Just tell him what your preferences are, and he can work with you. So current treatment approaches for active myeloma. Often the doctor, when he's talking to a patient, he's looking at you thinking, is this patient, a candidate for a stem cell transplant or not? If you are, you can get 3 to 4 cycles of therapy to reduce your myeloma burden. They can collect your stem cells or collect enough to store for another transplant. Some physicians do. Patients get high-dose melphalan and then go into a transplant. After transplant, after maybe 2 months when your marrow has recovered, now the standard of care treatment is putting patients on maintenance therapy. So we put patients on, which was approved, lenalidomide is approved by the FDA for maintenance post-transplant, and this helps us to keep your disease in control. If you're not eligible for transplant for whatever reason, or sometimes patients have the preference, they don't want a transplant, and there's nothing wrong with that. So don't think that just because you chose not to have a transplant that maybe you're missing out by not getting one. And I can tell you that I have many patients in our practice that do not want to have a transplant for whatever reason or are not eligible, and the novel agents that we are able to offer our patients, keep patients in a great remission, and they can cytoreduce their disease, and patients have a good quality of life. So just always need to keep that in mind. And, consolidation and maintenance and continuous treatment is key in multiple myeloma, along with supportive care, such as, bone strengthening medicines to, keep your bones healthy, making sure you're getting the vaccines that you need. If you're fatigued, getting red cell transfusion if needed. The main class of drugs we use to treat myeloma are the immunomodulatory class. It's the thalidomide, Revlimid, and Pomalyst. We have the proteasome inhibitors, Velcade, Kyprolis, and Marrow. Very excitingly, we have the monoclonal antibody therapies. These are used to enhance a patient's own immune system. And the histone deacetylase inhibitors, the Faradex. All of these drugs are usually used in combination with a steroid. They be used with another drug. So exponentially, we have more options for patients to treat their myeloma. So these are very exciting times. So with the class of the immunomodulatory drugs, this is very exciting because they're all oral medications. They're once-a-day dosing. This can be used for patients who have newly diagnosed myeloma in combination with dexamethasone, or newly diagnosed and relapsed refractory myeloma in combinations with other therapies, in Pomalyst for relapsed refractory patients in combination with dexamethasone. Some of the side effects that we can see, and really just to talk about all side effects, like all medications, the drugs used to treat myeloma have the potential to cause side effects. Side effects vary with different drugs and dosages, and it's important to know if you experience any of these, you need to talk to your doctor about them. Any of these drugs can cause a potential for a blood clot, and so we know how to handle that. Rash, fatigue, diarrhea, we always, constipation, we always make sure patients have anti-diarrheal medications at home. If they have a rash, they have, antihistamine at home. And also through dose modifications, patients, can feel better. Say if they're having fatigue, with a lower dose, they can feel better. Management, I talked about with immunomodulatory drugs, blood thinners are important. So everybody should be on a blood thinner, starting with a full dose aspirin if they have no risk factors. If patients have risk factors where they've had a prior clot, they need to see their hematologist for suggestions of some of the newer anticoagulation drugs out there. Sometimes patients can get cramping, and so there are supplements and vitamins out there, but you need to talk to your doctors about which ones you can take, to prevent some of these side effects. But Imodium for, issues with diarrhea or dose reduction. Sleep hygiene, I tell a lot of my patients to take these drugs at bedtime, then you can sleep off some of the side effects. And some of most especially Pomalyst can make patients feel tired, so you can take it at bedtime or dose reduce for fatigue. Proteasome inhibitors, another class of drugs. This is great. We have Velcade, which can be given as the quick IV infusion, but was approved for subcutaneous injection. The subcutaneous injection can go into the thigh or into the abdomen for newly diagnosed myeloma or relapsed refractory. The Kyprolis is an IV infusion, and just 2 weeks ago, very excitingly, it was just approved for once weekly dosing. So you don't have to go in those 2 days in a row. So it was once weekly dosing. They had great overall in survival and progression-free survival and great responses with the once weekly at a higher dose. This is for relapsed refractory patients in combination with dexamethasone, and Revlimid can be added as a triplet. Marrow is a first generation oral proteasome inhibitor, and that's a once weekly pill for relapsed refractory myeloma, combination with Revlimid and dexamethasone. So some of these side effects, which I talked about before, everybody can experience side effects, and it depends on the dosing. And so you can get dose reduced. With Velcade, we know there's peripheral neuropathies, and now that the Velcade can be given sub-Q, we see less of the peripheral neuropathies. But any of the side effects, low platelets or low counts, you can see with Velcade, Kyprolis, or Marrow, this can all be managed through appropriate dose modification. Not everybody can take the right dose. We individualize treatment for every patient. So when the doctor says we may need to dose reduce, people get upset and think, I'm not going to get the efficacy that I need because it's a lower dose. That's not the case. Everybody is individualized. So looking at more management, other peripheral neuropathy preventions, vitamins, or other certain medications you see listed here. It's very important for you to talk to your doctor prior to doing any of these medications or supplements. Acupuncture can help with peripheral neuropathies or physical therapy. Just wanted to point out any patient who's on a proteasome inhibitor or on a monoclonal antibody, you need to be on the shingles prevention pills, the antiviral pills. We always tell patients they can't have the live vaccine, but just recently approved is a vaccine to prevent zoster, which is called Shingrix. And you can ask your physician about it, that you get one injection, then 2 to 6 months later you get the second injection. This can hopefully prevent the reactivation of herpes zoster. So just check with your doctor regarding that. So the monoclonal antibodies, this is just so exciting that we have these. They're both approved in November of 2015. They're both IV drugs, both given for the first 2 months weekly. With Implicity, it's given every 2 weeks continuously. With Darzalex, the drug is given every 2 weeks for 4 months, and then it's given monthly. The drugs are in combination with Implicity, with Revlimid and Dexamethasone. And with the Darzalex, it's given with a combination of Rev, pomalidomide, or Velcade, but now it's approved with Velcade, melphalan, and prednisone for patients who are not eligible for a transplant. Side effects with these drugs are very minimal, as you can see. Infusion-related reaction can happen with Implicity and Darzalex, but it only would happen with the first infusion, not the first cycle, just the first infusion. It's about 10% with Implicity, and we give everybody pre-medications because in anticipation of an infusion-related reaction. Darzalex is about 40% with the first infusion, and then you generally don't see it because we load patients up with pre-medications. So just keep that in mind. The side effects of steroids, the dreaded steroids that nobody likes, which is totally understandable, but steroids play a very important role in the treatment of myeloma. It does cause cell death to that abnormal plasma cell, and it also acts as an anti-inflammatory within the bone marrow to suppress those myeloma cells from over-proliferating. So we look here at the insomnia, fluid retention, mood changes. These can all, get a little bit better with dose modification and changing in your schedule. But patients suffer from terrible insomnia. So I tell my patients, take your dexamethasone at bedtime and sleep off those side effects, because by the time they kick in, it's the next day. So that's, but you have to give it a chance and try it for a whole cycle. But AM or PM dosing can help with that. Fluid retention and mood anxiety changes, again, dose modification. The mood changes are usually the worst for patients, and so this is where some difficulty happens. Making sure you take your steroid with food, and also monitor your glucose levels because they can rise with dexamethasone. So myeloma relapse, what is the definition? What do these words mean to us? Relapse is recurrence after a response. So you've been on therapy for months and months and months or a year, and then you start to relapse. You never start to progress. That's called a relapse. Refractory is when you're on therapy and you're not having any response at all. So that would be refractory to that therapy, and then you can go on and the doctor will change your therapy. So the main points about relapse or refractory myeloma is that it's very treatable. Patients typically receive multiple lines of therapy. So this is what we see. And so as a patient with myeloma, the expectation is that, you're going to be on treatment for an extended period of time. This is just the reality of it. Is that in our practice, we treat patients until progression. I have had patients in my practice who have been on therapy for years and years and years. So that's kind of the expectation you need to set. 6 new drugs I just talked about were introduced in the last 6 years. And with the introduction of these new drugs, we have potential additional combinations. So exponentially, we have more therapies out there for the patients with myeloma. And we certainly know there's many promising new drugs in combination in clinical development. And I always say consider a clinical trial, because without the clinical trials that the patients who are on this call have participated in, we would never have the new drugs that we have today. So I want to say thank you for that, for participating in clinical trials. So on the horizon, as you look at this slide, I love this slide because the evolution of myeloma treatments, 11 new drugs approved within the last 15 years, and I will tell you, we have many, many more of these drugs that are on the horizon. We know that myeloma is highly treatable. In the last decade, we've seen significant advances in the diagnosis, in the treatment, in supportive care for our patients, and many new therapies are under investigation, bringing promise of better treatments to combat drug resistance in relapsed multiple myeloma. So with the impact of clinical trials in myeloma, dramatic improvements in survival for patients in less than 10 years. We know that survival rates nearly doubled, great improvements in the future, 11 new drugs since 2003, many clinical trials. And what's most important, too, is that the understanding of the biology of myeloma is improving with the eventual goal of personalized medicine. And so I can just kind of end this with just saying, as a clinical research nurse, I am so proud and so very grateful to have been a part of the research that's happening in multiple myeloma today, and very proud that I work at Dana-Farber, where research and where everybody is just so dedicated to looking for the advancement and the treatment for multiple myeloma. So with that, I just want to say thank you so much for your attention, and I'll be on the call if you have any further questions. Thank you so much.
Okay, thanks, Kathy. And now we're going to turn the webinar over to Alan and Deb.
Thank you. First of all, I'd like to begin by just saying it's a pleasure to be here, and we thank all of you for tuning in to us, and we hope that what we have to say today will be very helpful. Just to give you a little background information, I was diagnosed with multiple myeloma in November of 2008, nearly 10 years ago. Needless to say, the diagnosis came as a shock because I had always been a fairly healthy, active individual. Now, my diagnosis came about because I had been experiencing back pain, and an MRI showed that I had a mass on my spine. That mass turned out to be a plasmacytoma. So the first step for me in treatment was radiation to reduce the plasmacytoma and to reduce the pain. That was followed with 6 cycles of Revlimid, Velcade, and Dexamethasone, which put me in remission. Now, even though I was in remission, we followed up with an autologous stem cell transplant. The transplant was successful, and testing showed no sign of the myeloma. After that, I was on Revlimid as a maintenance therapy for 6 years.
When Alan was initially diagnosed with multiple myeloma, we met with his medical team to discuss treatment options. It was at that meeting that I was referred to as the caregiver, and I distinctly, to this day, remember feeling overwhelmed and somewhat anxious. I knew the meaning of the word caregiver, being one who gives care, but in this whole new world of ours of multiple myeloma, what did that actually mean for me? And most importantly, was I qualified to fulfill the responsibility? But since that diagnosis in 2008, I've had the opportunity to meet with other caregivers, and I've benefited from their experience. In an effort to help others, I've put together this slide on the role of the caregiver to outline the complexity of the role and how that role has changed throughout treatment. I'll touch upon each of these later in the webinar.
The main point of this diagram is to emphasize that the patient and caregiver are a vital part of the treatment team, as Kathy mentioned earlier. The arrows in this diagram point to and from the patient and the caregiver to the various members of the treatment team. And that's to emphasize that it is important to establish effective two-way communication among all members of the team. Although most members of the team listed in this chart are rather obvious, there are a couple that I want to point out. First of all, your primary care physician should never be overlooked. Primary care physician should always be kept in the loop and up to date as to your situation. While being treated for multiple myeloma, it's also important that you not neglect other aspects of your health. Your primary care physician is the gatekeeper who will coordinate your overall health care. Also, your primary care physician may be the person that you need to turn to in the event of a health emergency. Another important person of the treatment team is the social worker. This individual will not only help you get through the emotional aspects of having cancer, but can also help with some of the practical aspects, such as arranging for housing close to the treatment center if needed.
As I now begin going through the slides that outline the responsibilities that a caregiver may assume, I'd like to caution all caregivers that, in my opinion, it's important to remember that the role of the caregiver is to be supportive. I personally had to learn the difference between being compassionate without being controlling, to empathize but not necessarily sympathize, and the balance wasn't always easy. In the role of the treatment coordinator, the caregiver may help in scheduling appointments and arranging transportation. They may help by getting prescriptions filled or by creating a dosing schedule when the patient should be taking medications. When Alan came home after his stem cell transplant, together we created a chart of his daily medications and taped that list to the bathroom mirror. Each day, he followed that schedule and checked off the pills when he took them. In the next slide, Communication Facilitator, it shows the importance of having complete contact information. Knowing who to contact with questions and who to call in emergencies is an imperative. After all, emergencies don't happen at 9 o'clock on a Tuesday morning. They usually happen over the weekend and after midnight. I found it helpful to make sure that I had the business card of everyone on the treatment team. I found that having the cards was comforting. I always knew that I had someone to call. As the communication facilitator, I think one of the most important things a caregiver can do for the patient is to be that second set of ears. When meeting with anyone related to the treatment team, listening and understanding what is being said is absolutely critical. Remember to ask questions and get clarification if necessary. Take notes. Many people even record sessions, and let your providers know what's working and what's not. How are you managing those side effects? And let them know what your goals are.
I don't think we can overemphasize the point that for your myeloma treatment to be most effective, the patient and caregiver need to play an active role in the management and treatment of the disease. We have already stressed that it is important for you to educate yourself as much as possible about the disease itself. Later in this presentation, we're going to provide you with some resources that will help you in this regard. In her presentation, Kathy talked about lab results. Many tests will be run, and it can be difficult to keep track of all of them from one visit to another. We try to focus on the ones that are most important in terms of my own situation and my own type of myeloma, and we then track them from month to month on a spreadsheet. Although I'm in remission, I recognize that a relapse is possible at any time, and for that reason, I always try to keep abreast of the current treatment options. That way, if I do relapse, I won't have to start at ground zero in deciding what option may be best for me.
As a caregiver, it may also be necessary to advocate for the patient. During treatment, the patient may not always be feeling well enough to speak up for himself or herself. In that role, the caregiver should be prepared to make sure that the needs of the patient are being met. Let others know what's helpful and what is not. Running interference may be necessary to ensure that the patient's best interests are being realized. In daily living, I have always considered our journey through multiple myeloma to be a team effort, and that effort is best exemplified in daily living. Alan and I work as a team to make sure that we're both eating properly, exercising, and getting enough rest. We also structure our calendar to make sure we maintain social contacts, but we're very much aware, especially at this time of the year, to be mindful of others who may be sick and try to avoid taking any unnecessary risks of exposure to illness. In the next slide, support. A caregiver can be most supportive when they have taken the time to learn as much as they possibly can about the disease. In being educated about multiple myeloma, the caregiver and patient are better prepared to know what to expect. Having that knowledge makes assisting with decision-making, maintaining a degree of normalcy, and understanding the patient's fears, anxiety, and frustrations easier. I highly encourage all caregivers to seek help when needed. In taking care of yourself, oftentimes caregivers are so immersed in caring for patients they forget to care for themselves. I'm reminded that if oxygen masks are needed on an airplane, the flight attendant always instructs you to place the mask on yourself before assisting others. Caregivers need to follow that same advice. If you don't care for yourself, you will not be effective in caring for the patient. So as the bullets on this slide indicate, you need to pay attention to your own needs. Again, make sure you're eating properly and getting enough rest. If things seem to be overwhelming for you, don't hesitate to ask for help. Many people are willing to help, but they're just not sure what they can do. For us, learning more about multiple myeloma not only gave us insight about what to expect, but it also gave us a feeling of control. By knowing more about the disease, we could anticipate some of the challenges and be better prepared.
Throughout this presentation, we've stressed the need for you to educate yourself as much as possible about your disease and treatment options. In the next few slides, we're going to talk about some of the resources that we used and found to be very helpful. Now, when I was first diagnosed, my oncologist warned me about looking for information on the internet. As you all know, the internet is a great source of information, but it can also be a source of misinformation, and this is true when it comes to multiple myeloma. Much of what is on the internet about multiple myeloma is either outdated or just plain wrong. First places we turned to for information were the websites of the MMRF, the American Cancer Society, and the National Cancer Institute. From these sites, we were able to get all the information we needed to understand my disease, know my treatment options, and make informed decisions. In addition to those listed on this slide, other organizations concerned with multiple myeloma, such as the International Myeloma Foundation and the Leukemia and Lymphoma Society, have excellent websites that are worth checking out. And also, don't overlook your own hospital or treatment center's website. This can also be a very reliable source of information. There is also a wealth of printed materials available, and much of it is free or at a minimal cost. A good place to start is with the MMRF Patient Toolkit, which contains several booklets that give an excellent overview of multiple myeloma and treatment options. Most importantly, it also contains a guide for caregivers. The other organizations noted on the previous slide also have excellent print materials. The MMRF also sponsors webinars, such as this one, throughout the year. These feature the top experts in the field on very specific topics. We have found them to be very helpful over the years. To get notified about these webinars, make sure that you get on the MMRF's mailing list. And also, as Mary mentioned earlier, past webinars are posted on the MMRF's website under Patient Education Programs, and they're worth checking out. Another great thing that the MMRF offers is an intensive one-day seminar for patients and caregivers. This is generally offered in many cities throughout the country every other year. Check their website for dates and locations near you. The treatment center may also offer educational seminars for patients. For example, the Dana-Farber Treatment Institute, where I was treated, offers an annual all-day patient seminar in December where they present the results of the latest research that has come out of the major conferences on cancer and myeloma. Now, if you have specific questions about your treatment, naturally your own medical team is the best source for getting answers. But also, I want to point out a great resource, and that's that the MMRF has a nurse that you can call at any time if you have specific questions.
In conclusion, both Alan and I believe in looking for the positive. No matter how challenging things become, we remain optimistic. As Kathy said earlier, the research done over the last 10 years is remarkable. It has given us hope for the future. Now we would like to turn the question and answer session back to Mary.
Thanks so much, Deb and Alan and Kathy, for your fantastic presentations. And I particularly like the way that you emphasize how much hope there is in the myeloma community and how much great work is ongoing in discovering new therapies and really finding ways to potentially reach toward a cure for myeloma. So now we're going to switch to the question and answer session. As a reminder to the audience, if you'd like to ask one of the presenters a question, just type it into the Q&A box and click enter. Your questions will be answered in the order in which they were received, but due to time constraints, we may not be able to answer all of your questions. So we've had a number of questions already proposed, and I'm going to start off with some of the ones that are asking some fairly important but general questions. And I'm going to ask both of you, Kathy, and then Alan and Deb, to respond with your answers to these. So with this one, I'm going to start with Kathy, and then Alan and Deb, you can chime in. We've had a number of questions asking about how important diet is when you're a myeloma patient, and whether or not it would be the best thing to do would be to hire a dietitian to help you. Can you comment on that, Kathy? And then Alan and Deb can give their response as well.
Okay, thank you for asking the question. Generally at every hospital or at every center, there is a dietitian or a nutritionist that is there to assist patients. And so you can ask your caregiver, you can ask the nurse if they can set you up with a nutritionist. I know that we have nutritionists that work with different disease groups. We have them working with multiple myeloma. So, I mean, again, it's always asking the right questions, and there should be somebody there at your center that can, set you up with a nutritionist. And obviously, good nutrition is very important. Not treating your myeloma certainly, but nutrition is just so it makes you feel good. And, avoiding sugars and things with high calories. For example, when you're on taking your steroid days, your Dexamethasone. I mean, we have like a 4-page handout that will talk about things that you should eat. I mean, because people have ferocious appetites. When they're on the steroids, they just want to eat. And so instead of eating sugars or candy, think about eating, vegetables and having, a lovely carrot stick instead of having that bowl of ice cream. And we have to also think about when you're eating. So, for example, with the steroids, the highs are high and the lows are low. So if you're having ice cream, the sugars make you feel high, but then you can crash very quickly. So you have to keep that in mind. But good nutrition, eating, vegetables and fruits is very important. Mary?
Just to add to that, we are also very strong advocates of the benefits of both diet and exercise. And I have to give Deb all the credit in the diet department. But one thing I just want to mention in that regard is that early on, my oncologist recommended the Mediterranean diet. So basically what you ought to be eating is what's on a typical healthy diet, and that's lots of fruits and vegetables and that type of thing.
Great. So, Alan, you already touched on what my next question is going to be. Several people have written in about exercise in myeloma and how important that is, and particularly exercise before people have their stem cell transplant and also in general. So if you guys could start, and then Kathy can also chime in.
Yes, again, my philosophy going into the stem cell transplant was I felt that the stronger I was when I went into it, the better I would be when I came out of it, and I think that's very true. No matter where you're at in terms of physical fitness, you can do something. And walking is a wonderful exercise. Everybody can generally get out and do a little bit of walking, and I highly recommend that. Many centers, Dana-Farber included, have exercise physiologists who could help you develop an exercise plan, and that's certainly worth checking into. Also, many YMCAs have a program in conjunction with Livestrong where they will give free membership to cancer patients, so that's worth looking into as well.
I mean, I could agree with what was just said is that, exercise is important because it makes you feel good. It's good for your bones. Walking is very good. And then have exercise, it's very good for your heart and making sure that your heart rate gets up and perfusing your body with blood. And so that's very important. But it's, walking and the exercise is good for bone strength. So it's definitely important for your bones. And it helps you to be, not become deconditioned, because if patients are suffering from fatigue, if they're from getting their medication, or if they have high burden of disease, it's just important that they don't get deconditioned. They need to be out, even if they're riding a bike. It's just working their lungs, and that's also very important too, because you don't want to end up with pneumonias. So just keeping active is very important.
So thanks, Kathy, and I know that that Alan and Deb, you mentioned about being really careful during cold and flu season to make sure that you're not exposing yourselves to people who are sick, so that you can keep yourselves healthy. We did have a question. I'm going to pose this one to Kathy about traveling, whether or not, when you have myeloma, it's safe to fly or not worth the risk. Because of the risk of catching a cold while you're on the plane, breathing all that air, that filtered air from other passengers, and also radiation exposure when you're flying.
Yeah, well, we can all be exposed to that. As far as traveling, we still want patients to maintain a good quality of life, and we have many patients that are, the snowbirds that want to come down to Florida. You just have to, just be smart about it. I know that, when I fly, I take those bacterial wipes and I clean the seat I'm sitting in, and the armrest, and the TV, and all of that. Some patients ask me if it's worth, wearing a mask or not. That air is being filtered. You may be inhaling that, but, there's nothing wrong with wearing a mask if the person next to you, is coughing. I know that if you're traveling, you have myeloma, patients are susceptible to infection, and I always suggest that they travel and ask their doctor for a prescription for an antibiotic, so in case they start to get some type of cold symptoms, that they can take something. Because a simple cold to a patient with myeloma, they don't have the immune system, and those plasma cells are not working and functioning properly to help prevent them from getting a full-blown upper respiratory infection from a simple cold. So, traveling with with an antibiotic, cleaning the seat or the area you're around. We don't want patients not to be, traveling, but if their immune system is really compromised, maybe the doctor may tell them to hold off and wait and just until they get better. So in the cold and flu season, some patients can get recurrent infections again because the plasma cells aren't working, the immune system is compromised, and oftentimes we have patients on gamma globulin. This is something else that can enhance their immune system, hoping to prevent the cold and flu that we can see with patients. And also walking around so they don't get a clot, exercise, moving their feet back and forth, keeping blood flow going. Okay, sorry.
That's important for everybody on the plane, for sure. So
yeah,
right. I have to say that, I do a fair amount of traveling, and you do see people walking around on planes much more than you used to. So I think that message is getting through. So that's great.
Yeah.
I've got a couple of questions. Oh, sorry. Go ahead, Kathy.
No, it's Deb. If I could just chime in on that, with the traveling, we take it one step further, and when we go into a hotel room, we make sure that we're using those wipes to clean the room as well. It's just another precaution that we use, and we find it very helpful.
Yeah, it's a great idea. So, Deb, I've got a couple of questions that are specifically for the caregiver, which is you. So I'm going to ask those now. One person asked, what were the greatest challenges for you as a caregiver after Alan had his stem cell transplant?
That's a great question. It is. I guess I was pretty amazed that it wasn't as challenging as I thought it was going to be. So I think I can alleviate some distress that people might be feeling about that. That when Alan came home, even though we kept the house really clean and we made sure that he wasn't in contact with anyone, aside from that, it wasn't any different than having someone home that maybe had a mild case of the flu. So I encourage all caregivers not to worry so much about when the patient comes home. Just take the precautions that you're given prior to leaving the hospital. They'll spend a lot of time with you explaining what needs to be done, what you can do, what you can't do, what you can eat, what you can't eat. And I think it's not as challenging as you might think.
Okay, that's great advice. And then someone else, I know that Kathy, when she was talking about dexamethasone and some of the side effects of that drug, which many, many people have difficulty with, somebody wrote in and asked about whether or not you had to deal with some of the side effects of dexamethasone when Alan was taking it, such as some mood swings and things like that. And I know Alan is listening, but you know, please let us know how that all worked out.
Yes, as far as that goes, I think the best advice is you need to take a deep breath and be prepared to walk away. And that's what I tell most people. That
that's great advice.
It is challenging, but you have to remember that the patient, it's an effect of the medication, and it's not personal. And I think that's where people stumble, because it does become quite challenging. And as I said, the best advice, what I did, is just take that deep breath, know that tomorrow will be better, and just walk away.
Sounds like good advice to me. Okay, so this next question is for Kathy. So someone wrote in and asked about the flu immunization and which flu immunization is recommended for myeloma patients.
Oh, okay, thank you. So with the flu vaccines that we have out, and it's up to your doctor. There's the flu 13 or 23 that, you know, again has more of the antibodies that they're hoping that's going to try to prevent patients from getting the flu. So, you know, again, it's up to your doctor, and if you're over a certain age, they're going to recommend, I think it's the vaccine 23 that has obviously looks at more of the antibodies that you would need, you know, to hopefully combat the flu season.
Great. So this is another question for you, Kathy, and a listener wrote in about the M-spike protein test and how important that is in really indicating where your disease is. And the questioner noted that it really seemed to have an effect on the mood of the patient that this person is a caregiver for. You know, seeing the numbers go up and down a little bit really affected the way that they felt about their disease and about their prognosis in general. So can you, just sort of, give us an idea of the M-spike numbers and how big a change is really significant and how people should really let that affect them when they get the results of that test?
Oh, okay. Thank you very much. Well, I'm sure it's very difficult for patients who come in monthly, and then every month is when we will do the test for their serum protein electrophoresis. And looking at those numbers, tells us if the patient's, responding to therapy or if they're progressing on therapy. But these numbers, they vary. There's a lot of flexibility in these numbers. And so, psychologically for a patient to look at these numbers and they could be low, but they may have an M-spike. So the M-spike itself, like when you're looking at the M-spike, that looks at the concentration of those abnormal plasma cells, and everybody wants it to be, have no M-spike, and that's great. We'd like that for everybody. But, the thinking has changed when we treat myeloma, and what we're looking for is control of the disease. So I have had patients who have had an M-spike of over 1. I've had a patient who had an M-spike of 2 that they had it for years. And this patient we just monitored, and it happened not to even be on therapy. But the really is important is that we need to control the disease. So if they have a small M-spike, if it's there and there are small fluctuations, so if it goes from a 0.34 to a 0.48 or something, again, there's a lot of variability. within that number, because we have to remember in the plasma cells, there are good plasma cells and there are bad plasma cells. And so, so you can see sometimes the IgG or the IgA number rise, and especially in light if somebody has an infection. But looking at the M spike, there can be variability when the pathologist is looking, at the slide and looking at the blood and, and counting that grid and seeing how many plasma cells that they have. So, psychologically, a patient's looking at that and saying, oh, it went up a little bit, I'm not doing well. And actually, that's not the case. I mean, your care team, watches these numbers all the time. And it might be a biochemical, a little bit of a progression, but you may not have any other symptoms. You may not have bone pain. You may not have fatigue. You're not feeling anemic. But if there's a small fluctuations of them going up, I mean, that is fine, because we're going to see that variability. And sometimes, in that M spike could be some normal plasma cells. So the patient, and when the doctor's explaining the serum protein electrophoresis to them, sometimes if the numbers are small, they can't even quantify it and can see normal cells in that. So it can affect the mood, sure. Everybody gets upset if they see it going up a little bit, but then the next time they come in, it could go down. As long as we can control that number, and if it fluctuates a little bit, I mean, you're way ahead of the game, because the controlling of the disease is what we're trying to do.
Alan and Deb, do you have anything to add to that? I mean, was that ever something that you experienced, during your course of the disease, just sort of really, obsessing over your M spike numbers?
I can understand how people can get a little overly concerned about it. In my case, since my stem cell transplant, my M spike has always been undetectable. But I have had some other lab results that from time to time have fluctuated. In particular, I remember one time when my IgG count went up, what I thought was a lot. But we just repeated the test a couple of weeks later, and it was absolutely fine. I think what you have to keep in mind is that, they could draw a vial of blood from your left arm and then draw a vial of blood from the right arm, and you might get two different results from the lab. Your test results will normally fluctuate, so don't panic. Trust what the oncologist tells you in terms of interpreting those results.
That's super good advice. Okay, so we're almost out of time, but I have one more question that I wanted to ask you, Alan and Deb, and you did touch on this during your presentation, but I really want to emphasize the importance of effective communication between patients and caregivers and their treatment teams and healthcare providers. So can you talk a little bit about that and go over again, or really emphasize your best tips to be able to optimize that type of communication and how important it is?
I think one thing that we do to optimize the communication is that we usually come to appointments prepared with questions. And sometimes when you come into an appointment, you're a little bit nervous and you don't remember all your questions. So it's always a good idea to just jot them down. The other thing Deb mentioned in her presentation, the importance of the caregiver being a second set of ears. And I don't think that can be overemphasized. We have found many times that we leave an appointment and we discuss what was said at the appointment, and very often each of us picked up something different. So that's critical. But one thing I mentioned is the importance of keeping your primary care physician in the loop, and I think that is also extremely important. You have to make sure that the primary care physician gets all of your test reports, all of your lab results, and if they're not being sent from your treatment center, then you need to hand carry them to the primary care physician. And that way, everybody is basically on the same page.
And I would just have to stress that if you are not clear, if there's something that you don't understand, then go back and ask for that clarification. Don't be afraid to do that. Doctors prefer, Kathy will tell you, that whole medical team would rather you ask the question so that they can make sure that you understand it before you leave there. So always ask for clarification. It's something that I feel is vital.
Yes, very important. I agree wholeheartedly. We want to hear from the patients. We want them to ask the questions.
Okay, that's perfect. Thank you so much. That concludes our question and answer period. That's all the time we have for today. So on behalf of the MMRF, I'd like to thank Kathy, Alan, and Deb for presenting today. Really useful presentations. I hope everyone enjoyed them. I'd like to thank everyone for joining the webinar. And finally, I'd like to thank our sponsors, AbbVie, Amgen, Bristol Myers Squibb, Celgene, Genentech, Janssen, Karyopharm, Novartis, and Takeda Oncology for sponsoring this webinar.
Well, thank you very much for having us.
Sure.
Thank you.
So as Alan and Deb mentioned, we do have this webinar series that is ongoing. We have one more for 2018 on tap that's coming up on November 7th. So that is on understanding the difference in incidence and treatment in multiple myeloma in African American myeloma patients. So that's coming up on November 7th. We encourage you to register for that. The information is there on our website and on the slide. We also have one more of our full-day patient summits coming up on Saturday, November 10th. It's going to be in St. Louis at the Washington University School of Medicine, and it's going to be hosted by Dr. Ravi Vij, who is a member of our Multiple Myeloma Research Consortium and a great friend of the MMRF and patients everywhere, a very dedicated physician. So if you live in that area and are interested in attending that summit, please go to our website to register, and again, the information is there. Deb and Alan mentioned resources that we have available for you, in particular our Patient Support Center. We have 2 nurses that are available to answer your questions. You can go to our website and see the phone number there. It's listed very prominently. You can call them or you can also email them. So that information is listed here on the slide. And also, again, stay connected. We encourage you to stay connected to us on our social channels, our Facebook groups, our Twitter, and on our website, so that you can be educated and be aware of all the great things that are happening in the multiple myeloma community.